All right, I don't think today is a long lecture. So I'm gonna wait just another couple minutes.
Audio, James.
I'm sorry? Oh, somebody asking about my audio? All right, I'm speaking. I don't know if anybody can hear me. I'm going to put this in the chat.
Yep, I can hear you.
Okay.
We cannot hear you now.
Okay, so Nevada says she can, and Will said, yeah, Nevada, Lily.
Never mind. It's just my computer.
Yep. Okay.
All right.
All right, and we are recording this so that those people who didn't get my email until late can watch the recorded version. Let me go ahead and share the PowerPoint. I'm going to try to aim this thing towards the screen, but I have a feeling you're not going to be able to see what I'm pointing at over on the screen. I'll try to use my cursor and point at things on the PowerPoint slides over here.
I think you may have some sort of filter set for your background that kind of blurs out the black.
I don't have that on purpose, but let's see if I can get rid of that. Let's see here.
Backgrounds and filters.
Yeah, that could be. Okay. I think it was set to blur. There we go. Must be a default or something because I don't normally do that on purpose. All right, I'm gonna actually change the lighting here. I don't know if that's better or worse. All right, let's give this a try. There we go. All right. Those of you watching remotely, can you see the PowerPoint full screen?
Yep.
Okay, great. All right, so let's go ahead and get started then. So what I'm going to talk about today is actually what you all dissected yesterday. So hopefully this is going to be largely reviewed. So I'm going to talk about the gluteal region and the posterior thigh. So you've seen this picture before. You've seen this illustration that shows a series of axial or transverse cross sections through the thigh, showing the different muscular compartments. So last week, on Thursday, we dissected the anterior compartment of the thigh, which includes the four quadriceps muscles plus the sartorius muscle. These muscles are mostly involved, a couple of them help to extend the hip, flex the hip, and most of them are also involved in extension of the knee. And all of those anterior muscles are all innervated by femoral nerve. Also, last Thursday, we looked at the medial compartment. This includes things like gracilis, pectineus, and three adductor muscles, adductor longus, adductor brevis, and adductor magnus. Most of these muscles are adductors of the hip, so they're going to pull the thigh medially, in towards the midline of the body. The exceptions would be Actually, the only exception to that would be pectineus, which acts as a flexor of the hip along with the anterior muscles. Most of the medial muscles are also innervated by obturator nerve. The exception to that is also pectineus, which is innervated by femoral nerve. But the others are all innervated by obturator. We've also talked before about the iliopsoas. So those are muscles that originate inside the abdominal cavity and the pelvic cavity. So the iliacus that originates from the inside of the ilium, the psoas major that originates from the lumbar vertebrae. They then join together to form something called the iliopsoas tendon, which crosses over the front of the pubic bone and inserts on the lesser trochanter of the femur. And these are also extensors of the hip, or extensors of the thigh. So today we're going to talk about the remaining muscles in the posterior aspect of the gluteal region, the buttocks area, and then continuing down into the posterior thigh. So these are really two separate muscular compartments. In this upper cross section, you can only see gluteus maximus, but as you saw yesterday in lab, there's actually a lot more going on in the gluteal region higher up, in the posterior aspect of the pelvis. So there's a lot of other muscles besides just gluteus maximus, just that that's the only one that continues this far down into the thigh to be visible in this cross section. And we'll also talk about the posterior compartment of the thigh. These are the muscles that we generally call the hamstrings. That's not 100% correct. There's one muscle back here that's not a hamstring. But for the most part, we think of these being hamstrings in the back of the thigh. They play a role in helping to extend the hip, so moving the thigh posteriorly at the hip joint. And also, they are the primary flexors of the knee. Right, so here's an overview of a superficial dissection of this area. So this is what your cadaver should have looked like yesterday after you reflected the skin out of the way. So you can see in the upper part of the slide, in the gluteal region, the one big gluteus maximus muscle that completely covers the gluteal region posteriorly. And then inferior to that down here, we have the posterior compartment muscles. I'm going to walk through the entire gluteal region first, and then go back a few slides and revisit the posterior thigh. So let's focus just on the gluteal region. So starting with the gluteus maximus. It has a somewhat complicated origin because it originates from several different structures. So part of it's originating from the iliac crest. So I need my little pointer here, need a longer pointer. Way up here, you can see the most posterior part of the iliac crest with a little bit of the gluteus maximus originating there. Then the muscle originates all along the posterior surface of the sacrum and even down here on the coccyx, but also on the deep surface of the muscle. You remember, I think I pointed this out to most people in lab, or made them aware of this, that the deep surface of the muscle is also partly originating from the sacrotuberous ligament. There's a ligament under here originating from the sacrum and connecting to the ischial tuberosity, which is buried in this area. And so part of the muscle is also originating from that sacrotuberous ligament. And you detached the gluteus maximus muscle from its entire origin yesterday, cut it away from iliac crest, sacrum, coccyx. And I asked you to try to carefully shave it off of that sacrotuberous ligament, but ideally leave the ligament intact because it's a good reference point for some other deeper anatomic structures. The insertion of the gluteus maximus is partly on the femur itself. There's an area right here in the middle called the gluteal tuberosity, which lies between the greater and lesser trochanters on the posterior surface of the femur. But part of the muscle also blends in with the fascia lata. Remember, the fascia lata is just a fancy name for the fascia of the thigh. It literally means the wide fascia that goes all the way around the whole thigh. So part of gluteus maximus just merges with that fascia lata. The gluteus maximus has a couple of functions. By far, its most important function is that it is the primary extensor of the hip. So remember, at the hip joint, this is flexion, bringing the thigh forward, but extension is the opposite motion, bringing the thigh posteriorly at the hip joint. So gluteus maximus is the primary extensor of the hip, which means that that extension motion of the hip is really important just for things like walking and running. So you plant your foot and then you extend the hip joint, you bring the thigh posteriorly, but what that does is it drives the body forward. So that motion, it's mainly that gluteus maximus that's driving that hip posteriorly and therefore driving the body forward. The gluteus maximus, because of its angled orientation here, it's inserting partly on the femur here and wrapping around the back of the femur. You might also be able to imagine that those fibers are going to pull in this direction. They're going to pull the lateral part of the femur out here, that greater trochanter. They're going to pull it in a medial direction, which is going to have the effect of externally rotating. And see, you can see what I'm doing here. So when you pull the greater trochanter that way, it's going to externally rotate the whole thigh so that the toes point laterally away from the body. So in the front view, probably when you pull the greater trochanter posteriorly and medially, it has the effect of rotating the entire thigh, the entire femur. So the toes point laterally, so that the external rotation or lateral rotation of the thigh. So let's dissect a little deeper. By the way, I think I pointed this out also in lab yesterday. The gluteus maximus muscle ends along a line here, but then it continues as a really tough fibrous membrane that covers the upper end of the gluteus medius, which is the next muscle we're going to look at. So in lab, you had to incise along that membrane to then be able to get under the gluteus maximus to reflect it. When you reflect the gluteus maximus, it's going to look roughly like this in the gluteal region. So just to remind you, we cut the gluteus maximus away from its origin up here on the iliac crest, on the posterior surface of the sacrum, and even down here on the coccyx, but also the deep surface of the muscle. We had to shave it away from this sacrotuberous ligament that connects the sacrum to the ischial tuberosity. And so then we reflected the gluteus maximus muscle laterally and inferiorly, similar to what's being shown here. And we've got greater trochanter under there, as well as gluteal tuberosity, and then part of the fascia lata right there, which is the whole insertion of this. So this is very similar to the dissection you did yesterday. And then that exposes the whole gluteus medius up here. In this particular painting, Netter has cut away part of gluteus medius. I asked you not to do that, just leave the gluteus medius intact. But you can see the whole gluteus medius there in this painting. So you can tell that the gluteus medius is originating on the outer surface, the lateral surface of the ilium. And it inserts right here on the tip of the greater trochanter of the femur. Just deep to the gluteus medius is a very similar muscle called gluteus minimus. I had you just kind of put your finger in the space between medius and minimus without actually cutting either muscle. Gluteus minimus has the same origin insertion, lateral surface of the ilium, and inserts on the tip of the greater trochanter of the femur. Both of these muscles have the same function. I mean, they're essentially almost the same muscle, really. Same origin, same insertion, same action, same innervation, everything. So when they pull up on that greater trochanter, when they lift the greater trochanter up towards the ilium, that's going to have the effect of abducting the thigh at the hip joint, or abducting the femur at the hip joint. So gluteus medius and minimus are the two powerful abductors, ab with a B. They're assisted in that motion by one other muscle that we've already talked about. Anybody else? Anybody remember that other muscle over here on the side that helps to abduct the hip?
Is it tensor fascia lata?
Tensor fascia lata, thank you, over there. Yeah, tensor fascia lata, which originates on the ilium, inserts into that iliotibial band, which is just part of the fascia lata. And so when that pulls, it lifts up on the lateral side of the thigh to abduct the hip. So those are the three abductors: gluteus medius, gluteus minimus, and tensor fascia lata. Those three abductor muscles they all share the same innervation. There's a little nerve shown right here. It's coming out of the pelvis just above this little muscle, which we'll talk about later. A little nerve right here called the superior gluteal nerve. That's the nerve that innervates gluteus medius, gluteus minimus, and tensor fascia lata. And I realized that I neglected to tell you the innervation of the gluteus maximus earlier when I was describing that muscle. This little nerve right here, exiting the pelvis just below this muscle, that's the inferior gluteal nerve. And that would be the innervation of the gluteus maximus. That's the only muscle innervated by the gluteal nerve. It's just the gluteus maximus. All right, let's continue a little deeper in the gluteal region and zoom in to start talking about some of the other structures in this area. So once again, in this illustration, the gluteus maximus has been cut and reflected, but when Netter painted this one, he painted the reflection of the gluteus maximus a little bit differently than the way we did it in lab. So here it looks like he kind of cut out the middle of the muscle and left the origin and the insertion intact, which is different from what you did. The nice thing about it, though, is it allows you to more clearly see the innervation of the gluteus maximus. So let me first talk about all the muscles here that lie deep in the gluteal region, and then we'll come back and talk about the nerves, as well as arteries, which are labeled on here, but they're not actually shown in the picture. For some reason, Netter never did a painting of the arteries of the gluteal region. I haven't had time to get around making them. So once again, we've got gluteus maximus coming from iliac crest, sacrum, coccyx, and sacrotuberous ligament right there. And then inserting down here on the gluteal tuberosity and also blending in with the fascia lata of the thigh. Gluteus medius up here coming from lateral surface of ilium, inserting on the greater trochanter right there. Gluteus minimus with those same attachments, ilium, greater trochanter. Just inferior to the gluteus medius and minimus, we find the next little muscle here in the gluteal region called piriformis. And I think everybody identified piriformis in lab yesterday. We've actually talked about piriformis before, back in the first lecture in this unit when we were talking about the structures on the inside of the pelvic cavity. Because the piriformis is actually originating from the anterior surface of the sacrum, which is actually in the true pelvis, inside the true pelvic cavity. So piriformis is actually originating from the front of the sacrum, inside the pelvic cavity. And piriformis has to exit the pelvic cavity in order to eventually insert here on the greater trochanter of the femur. It leaves the pelvic cavity by passing through a space that we've talked about quite a bit before, a space called the greater sciatic foramen. And that green dotted line represents the approximate location of the greater sciatic foramen. So piriformis muscle is actually exiting the pelvic cavity by passing through that greater sciatic foramen. Right. Inferior to the piriformis is a group of three little muscles. See the little group of three little muscles right here. Two of them have been partly cut away. There are two muscles called gemellus muscles. The more superior one that's right below piriformis, that's superior gemellus. And then the most inferior of those three little muscles is the inferior gemellus. And lying in between the superior and inferior gemellus is a third muscle called obturator internus. And I think I mentioned to many of you in lab yesterday that Netter painted this muscle wrong. It's a pretty glaring mistake, and I'm surprised that in spite of numerous editions of his anatomy atlas, nobody's ever fixed it. I guess I should talk to the publisher, volunteer to fix it for them. Netter is showing the superior gemellus, obturator internus, and inferior gemellus as looking virtually identical. There's a little short muscle belly and then a little short tendon. It never, ever looks like that. The muscle belly of the obturator internus is actually way over here. I don't know if the people at home can see what I'm pointing at. Let me get the cursor and see if I can point at that. The origin of obturator internus is way over here on the inner surface of the obturator foramen. Remember that the obturator foramen of the pelvis is filled in with a membrane, and there's a muscle originating from the outside of that membrane called obturator externus, which is in the medial compartment of the thigh. And then this muscle is called obturator internus, originating from the inner surface of the obturator membrane. So that's where the muscle belly is for obturator internus. By the time the muscle gets up here into the gluteal region, it's just tendon. So what we see in the cadavers is superior gemellus and inferior gemellus muscles where you can actually see the red fleshy muscle belly, but they're separated by just a white tendon, which is the obturator internus tendon.
Makes sense. Right, because gemelli is twins.
What's that?
Because in Italian, gemelli is twins. So I didn't
Oh.
understand why they were twins when there was like a third thing in the middle of that. But if there's no
Thanks to
twins-
Joseph for always knowing the Italian roots of these words. So gemelli means twins, okay.
Yeah, I mean, so. it must be
So it's
same.
the upper and lower twin
Yeah.
separated by that white line that the twins
Yeah.
paint down the middle of their rooms. Like you keep your toys and clothes on that side of the line, I'll keep
Yeah.
mine on my side of the line.
Right. But
Right,
I've
so,
only seen-
so now none of you will ever forget superior and inferior gemellus.
But it didn't make sense, because I've seen this image before.
So it didn't make sense
I
that
didn't understand.
that they were triplets. Why would they name them twins?
Exactly.
Right.
They're not.
They're not. All right. The last muscle located deep in the gluteal region is called the quadratus femoris. This is originating on the ischial tuberosity. And just like all these other muscles, it's also inserting into the greater trochanter of the femur. I haven't mentioned anything yet about the actions or innervations of these muscles. All of these little muscles, piriformis, the twins, obturator internus, quadratus femoris, all of those little muscles are lateral rotators of the hip joint. So remember that means rotating the thigh so the toes point away from the body laterally. Okay, so they're pulling the greater trochanter medially here and back, but that's going to have the effect of rotating the thigh so the toes point laterally away from the body. And you'll all be happy to know that you don't have to memorize innervation for any of these little muscles because each one is innervated by its own little nerve coming off of the lumbosacral plexus. So there is a nerve to the piriformis and nerve to the obturator internus. But that's all you need to know in terms of nerves. All right. That's all you need to know in terms of innervation for those little muscles. They all have their own separate little nerve. All right, speaking of nerves, let's go back and look at the nerves that are also shown on this slide. We talked about a couple of these a few minutes ago, but you can see them more clearly here on this image. So there's a nerve that exits the greater sciatic foramen immediately superior to the piriformis muscle. This is the superior gluteal nerve. And you can see that superior gluteal nerve lying in the plane between gluteus medius and gluteus minimus. And if you look really closely, if you follow that superior gluteal nerve laterally, almost over to the skin of the hip, you can see that the nerve is entering another little tiny muscle. There's just a little glimpse of another muscle sitting just lateral to the pelvis. That would be just a little bit of tensor fasciae latae, which is visible over there. And I'll point that out for people here on the Zoom. So you follow superior gluteal nerve over here, you can see just a little glimpse of tensor fasciae latae. So that superior gluteal nerve is innervating gluteus medius, gluteus minimus, and tensor fasciae latae. There's another nerve exiting the greater sciatic foramen, just inferior to the piriformis. And if you follow this nerve, you can see that it gives off a whole bunch of branches, but all of those branches are traveling to different parts of the gluteus maximus. This is the inferior gluteal nerve, which innervates just the entire gluteus maximus muscle. Then there's a bunch of other nerves that are also exiting the greater sciatic foramen, and they're also exiting inferior to the piriformis. One of these is the sciatic nerve, the largest nerve in your body other than your spinal cord. So this great big nerve is formed inside the pelvic cavity. Here's a tough trivia question, and I wouldn't be surprised if you might not know this one, but might be something good to brush up on for the exam. Does anybody know the spinal nerve levels that contribute to the formation of the sciatic nerve? This was shown when we did the pelvic lecture. S1 and 2 are two of them. What's that? And S3 also. And they join something coming from the lumbar spine also.
L4 and L5.
Somebody got L4 and L5. Right. And when the ventral rami of L4 and L5 join together, what do we call that? There's a name for it.
Lumbosacral trunk.
Right, the lumbosacral trunk. Good. So the lumbosacral trunk, which is L4-5, joins with S1, S2, and S3. And together, all of that makes up the sciatic nerve. Of course, all of that's happening inside the pelvic cavity. By the time we see the sciatic nerve, it's already joined together to one great big nerve and exits the greater sciatic foramen and then continues all the way down into the thigh, eventually all the way down to a point just a little bit above the knee. And then it splits. You might notice there's a long skinny nerve running right alongside the sciatic nerve. It doesn't have a label on here, but there's this long nerve running right alongside the sciatic nerve. That is the posterior femoral cutaneous nerve. So this would be the sensory nerve to the skin at the back of the thigh. Does anybody know what nerve is responsible for innervation of the skin of the anterior thigh? An anterior femoral cutaneous nerve, right? Good guess. That's right. More importantly, though, what other nerve is that a branch of? The anterior femoral cutaneous is a branch of some large nerve that we've talked about already. Femoral nerve, which supplies everything else in the front of the thigh. Right. And then lateral femoral cutaneous, innervating skin on the lateral side, we already saw that up inside the abdominal cavity. It's its own independent branch. There is no medial femoral cutaneous nerve per se, nothing with that name anyway, but the skin on the medial thigh is all innervated by obturator nerve, which also innervates the muscles of the medial thigh. All right, so far we've got superior gluteal nerve coming out above the piriformis, inferior gluteal nerve below the piriformis, sciatic nerve, posterior cutaneous nerve of the thigh, also coming out below the piriformis. And then finally, there's another little nerve way over here. If you look closely at it, you'll see that it's coming out of the greater sciatic foramen, and it's crossing over that white ligament right there, which isn't labeled. But the smaller white ligament that's kind of hiding inside that little hole, that is the sacrospinous ligament connecting the sacrum to the ischial spine. So this nerve, which is called the pudendal nerve, is exiting the greater sciatic foramen, crossing over the sacrospinous ligament, but then it actually goes back into the pelvic cavity right here through the lesser sciatic foramen. So it comes out just briefly for like a half an inch, then goes back into the pelvis through the lesser sciatic foramen and passes under this larger ligament, which is sacrotuberous ligament. You see it continuing down here. That pudendal nerve is a nerve to some of the muscles down in the perineum, what's called the perineum, which is the area basically between the external genitalia and the anus. So it's a sensory nerve and a motor nerve to structures down in that area. All right, in addition to the muscles shown here and all the nerves shown here, there are also arteries that are exiting the pelvic cavity by passing through this greater sciatic foramen. As I said earlier, Netter never painted them for some reason, and I haven't had a chance to go and try to add them. So I've just labeled them on this one slide. So in addition to superior gluteal nerve exiting above the piriformis, there's also a superior gluteal artery right next to it. There's an inferior gluteal artery running right alongside inferior gluteal nerve. There is no sciatic artery. There's no such thing as a sciatic artery in the body. So there's no big artery coming out here running along the sciatic nerve. The only other artery back here is called the internal pudendal artery. And that follows the same course as the pudendal nerve. Comes out the greater sciatic foramen, goes over the sacrospinous ligament, and then dives back into the pelvic cavity through the lesser sciatic foramen. I haven't been able to figure out why the nerve is just called pudendal nerve, but the corresponding artery is called internal pudendal artery. I'm guessing there must also be an external pudendal artery somewhere, so that just distinguishes the names. All right, so let's go backwards. And now we'll start talking about the posterior thigh. So just to orient you, over on the medial side of the thigh, which is on the left side of the figure, you can see the gracilis muscle running from its origin on the pubic bone all the way down to the tibia. Remember that the gracilis is one of the muscles in the medial compartment, so that's not really part of this posterior compartment. It's just drawn here just to help orient you. Over on the lateral side of the image, we have the part of the fascia lata. In particular, we have that iliotibial band or iliotibial tract or IT band. It's actually covering the muscle that would be kind of underneath this IT band would all be vastus lateralis, part of the anterior compartment. But then we get into the true posterior compartment. Some of you already discovered this yesterday when we were dissecting the posterior thigh, that it's really easy to get confused about what's medial and what's lateral. Because these two long skinny muscles right here look almost like mirror images of one another. So it's really important to remember which of these muscles is on the medial side of the thigh, which of these muscles is on the lateral side of the thigh. And when you go up to a cadaver on a lab exam, one of the first things you're going to have to do is orient yourself. Am I looking at the medial side of the leg? medial side of the thigh or lateral side of the thigh. And that's going to be true down here in the lower part of the leg too. You're going to want to know, am I in the medial or anterior compartment, lateral compartment, posterior compartment? Always look for two things to help orient you. Look for the cut section of the pelvis, because that's obviously going to be medial. Look for the big toe, because that's medial. That's going to help you orient yourself and know which. And it's especially true on this exam because since we've done a hemisection of the pelvis, one of the legs is cut off. I'm not going to rotate legs around just to screw you up, just to mess with your heads. But I am going to move legs around and rotate them into different angles just so we can see the structures that we need to identify. So there's no guarantee that that both legs are going to be in normal anatomic position. One may have the foot up by the head for all that, completely flipped around 180 degrees. So always look for those clues: cut section of the pelvis and big toe. Orient yourself to what's the medial side. All right. So speaking of medial side, in the posterior thigh, we have two rather long muscles that have the same origin, same insertion, and very similar sounding names. The more superficial muscle, or I guess you could say more posterior, meaning it's closer to the back and so it's more superficial. This is called semitendinosus. And it gets its name from the fact that it has a really long conspicuous tendon down here at its distal end. Has its origin up here on the ischial tuberosity, which you can't see at the moment because it's hidden by the gluteus maximus. But so ischial tuberosity, and then inserts down here on the tibia. Just a little bit deeper and a little bit more medial is semimembranosus. And this has a really broad, flat tendon, which I think is what gives it its name. It's like a big, broad membrane. We'll see it better in the next slide. But it shares the same attachments. It originates up here on the ischial tuberosity, inserts down here on the tibia. Over on the lateral side, we have one muscle, but it's one muscle with two heads. So it's the biceps femoris as opposed to the biceps brachii up here in the brachium. So literally means the two-headed muscle of the thigh, as opposed to the two-headed muscle of the arm. The long head also has the same attachments as these other two. It originates on the ischial tuberosity, inserts down here on the tibia, although it's the opposite side of the tibia. The short head originates directly from the femur. It's originating from the shaft of the femur, part of the linea aspera, just the posterior part of the shaft of the femur. And then it joins with the long head, and then together they insert on the tibia. So three of these muscles share the same attachments, and they also happen to share the same innervation. Semitendinosus, semimembranosus, and only the long head of the biceps femoris have their origin on ischial tuberosity, their insertion on tibia, and those three are innervated by what's known as the tibial division of the sciatic nerve. Remember that the sciatic nerve comes out of the greater sciatic foramen, runs through the gluteal region and down through the posterior thigh. Eventually, just above the knee, that sciatic nerve is going to split into a tibial nerve and a common fibular nerve. But even above that point, even above the split, we still sort of divide the nerve into two parts. There's the tibial part, which is destined to become the tibial nerve. So the tibial division of sciatic is destined to become tibial nerve. The fibular division of sciatic is destined to become the common fibular nerve. So it's that tibial portion or tibial division of the sciatic nerve that's innervating semitendinosus, semimembranosus, and long head of biceps femoris, long head only. The short head of biceps femoris, not only does it have a very different origin, it's originating from the femur as opposed to the ischium, it also has a different innervation. The short head of biceps femoris is innervated by that common fibular division of sciatica, not the tibial division. You all heard the term hamstrings. For most people, it's just sort of a general term that we use to describe all the muscles in the back of the thigh. But anatomists actually have a very specific definition for what constitutes a hamstring. The hamstrings are any muscles that originate on ischial tuberosity, insert on the tibia, and are innervated by the tibial division of the sciatica. So that means the only hamstrings in the posterior thigh are semitendinosus, semimembranosus, and only the long head of the biceps femoris. The short head would not be considered a hamstring, because it has a different origin and a different innervation. There is actually a fourth muscle that anatomists consider a hamstring. Some anatomists distinguish between the true hamstrings, which would be these three, and then a sort of a hamstring. Other anatomists lump this fourth muscle together as an actual hamstring muscle. So let me explain what this fourth muscle is that's sort of considered a hamstring. It's part of the adductor magnus muscle in the medial compartment of the thigh. So if you remember the picture of the adductor magnus, it's a great big long fan-shaped muscle that originates on the pubic bone and on the ischium and has its long insertion all along with the native spare on the back of the femur. But there's also a little piece of adductor magnus that inserts on something called the adductor tubercle on the medial aspect of the femur, just above the medium of the condyle. That's the part that lies beyond the adductor hiatus, the little hole in the muscle. Turns out that little part of the adductor magnus is considered a hamstring. If you follow that one portion of the adductor magnus muscle up to its origin, it's actually originating on the ischial tuberosity. Now, if you follow it distally to its insertion, it appears to insert on the adductor tubercle of the femur. So it doesn't seem to cross the knee into the tibia. But there's actually a ligament over here on the medial side of the knee joint. It's called the medial collateral ligament, which is actually a remnant of the tendon of the adductor magnus. And that medial collateral ligament does cross the knee and does attach to the tibia. So in a sense, that little portion of adductor magnus, the part that lies distal to the adductor hiatus, you could say that it attaches to the tibia because its tendon has left this remnant, which is the medial collateral ligament, which does cross the knee joint. And if you look at the innervation of the adductor magnus, most of the adductor magnus is innervated by obturator nerve, which is true of all of the medial muscles. But that one portion that goes from ischial tuberosity down to that adductor tubercle, that portion of adductor magnus is actually innervated by the tibial division of the sciatica. So that portion of adductor magnus, we actually call it the hamstring portion of the adductor magnus. It meets all of the criteria. Originates on ischial tuberosity, inserts sort of on the knee, and is innervated by tibial division of sciatica. Right, the muscles that you see here in the posterior thigh, semitendinosus, semimembranosus, and the two parts of the biceps femoris, most of those help to extend the thigh at the hip joint. So they help the gluteus maximus move the thigh posteriorly at the hip joint. That would be true for 3 of them, but not for the short head, because the short head doesn't cross the hip joint. But then all of them cross the knee joint, and all of them help with flexion. In fact, they're the primary flexors of the knee joint. So here you just see a little bit deeper dissection into the posterior thigh. You can see that well, up here, here's the ischial tuberosity now that's exposed. It's visible since the gluteus maximus has been cut away. So the long head of biceps femoris has been cut away, revealing a little bit better view of the short head. The semitendinosus has been cut away, revealing that big broad tendon that gives the semimembranosus its name. All right, we already talked about that slide. So let's move on and talk about the bones of the leg. And remember, to an anatomist, this is the thigh. Down here is the leg, only from the knee to the ankle. There are 2 bones in the leg, the tibia and the fibula. The tibia is the more medial bone, so the inner surface. The fibula is the more lateral bone. The tibia is also the bone that bears all of the weight in the leg. And the tibia is the only bone that actually participates in the knee joint. I mean, the tibia plus the femur, of course. If you look at the fibula, you see that the fibula does not actually extend up and articulate at all with the femur. So the fibula plays no role in the knee joint. It's just between the femur and the tibia. Before I start talking about some of these other bony landmarks, let me make an important point about illustrating these bones. If you take a look at the shaft of the tibia right in here, you'll notice the way Netter has painted this. He's painted the left side, facing towards the left side of the slide, as if it's kind of a flat surface, all with the same lighting. And then if you look at the right side of that same picture of the tibia, just in case you guys at home can't see here, if you look at the right side, you see that there's this big shadow. And it's all basically uniform value, suggesting that it's one big flat surface. And then there's this real prominent bright highlight running right down the middle. So the way Netter has painted this, it implies that we have 2 flat surfaces that are meeting at a sharp edge. Same thing if you look at the posterior surface, it's not exactly flat, but the posterior surface of the tibia is also relatively flat. What Netter is trying to get across here with the way he's painted the bone is that if you cut a cross section through the tibia, it's a triangle. The bone is triangular in cross section. It's not a cylinder. So when you draw the tibia, don't shade it as if you're shading a cylinder. Shade it as if you're shading it with 3 flat planes: a medial plane, a lateral plane, and a posterior plane. So like 3 sides of a triangle. The fibula actually has the same cross-sectional profile. The fibula also looks like just a smaller triangle when you do a cross-section. That doesn't come through quite as clearly on Netter's painting here. But understand that it basically has 3 flat surfaces forming a triangular cross-section. All right, so let's look at some of the landmarks here. Up at the proximal end of the tibia are a pair of condyles. Remember that the femur has 2 condyles called medial and lateral condyles. The condyles of the femur articulate with the condyles of the tibia. So there's a medial condyle and a lateral condyle of the tibia. Together, these 2 condyles form basically a flat horizontal surface At the top of the tibia is known as the tibial plateau. Something I didn't label in here, on here, I should probably have a label sometime. If you look at the middle of the tibial plateau, you see there's a little raised up area. It's kind of a little ridge that lies between the medial and lateral condyles. That's known as the intercondylar ridge or intercondylar crest. It's important because that's where the two cruciate ligaments attach. The ACL and the PCL have their connections on the tibia on that intercondylar ridge. In fact, you can see that on the left side. I can't quite reach up there or point to it, but those two ligaments attaching to the middle of the tibia up there. The one closer to us, to the front of the slide, is the ACL, and the one kind of hiding in the back is the PCL. Right, on the anterior surface of the tibia, there's a fairly large roughened area, which is the tibial tubercle. And this is where the patellar tendon or quadriceps tendon has its insertion. If you follow the tibia all the way down to the distal end of the tibia is articulating with one of the bones in the ankle, which we'll talk about next week. It's a bone called the talus that sits right here in the ankle, forms the ankle joint. And just on the medial side of the ankle, there's this little extension from the distal end of the tibia called the medial malleolus. So if you reach down and feel that bump on the medial side of your ankle, that's the medial malleolus, and it's part of the tibia. The fibula has a fibular head up at the proximal end, but remember that doesn't participate in the knee at all. It just articulates with the proximal end of the tibia. Down at the distal end of the fibula does articulate with the ankle joint. So the fibula doesn't participate in the knee, but it does participate in forming the ankle joint. And there's this extension from the distal end of the fibula called the lateral malleolus. So if you reach down and feel your ankle on the lateral side, that's the lateral malleolus formed by the fibula. And holding the two leg bones together is a very tough, fibrous interosseous membrane, very similar to the interosseous membrane that we saw in the forearm between the ulna and radius. One big difference, though, is in the forearm, that interosseous membrane accommodates a lot of motion, the motions of pronation and supination of the forearm. We don't have the same motions here in the leg. You can't like twist your whole foot over just by twisting your tibia and fibula relative to one another. The bones don't move very much relative to one another. All right, last thing I want to talk about today is a little bit about the knee, the actual knee joint. So here's an anterior view of the knee joint, but I think a lot of people get confused when they look at this picture of the knee. This is a view of the knee that's often reproduced in a lot of books, and you see a lot of illustrators creating this similar view. I think it's kind of like the way people illustrate the uterus. They don't understand the way the uterus really sits in the body. So everybody draws, touchdown uterus and Batman uterus and things like that, but they just don't know the way it really sits in the body. They just keep copying other people's pictures. So a lot of people draw a picture like this of the knee joint without realizing that you're looking at the knee like this. The knee is fully flexed. So you're looking at the anterior surface of the tibia, but you're looking at the inferior surface, the distal end of the femur. And that's where you see this big sort of U-shaped or horseshoe-shaped cartilage surface. That's on the distal end of the femur, not the anterior surface of the femur. And I think I've even drawn it wrong like this way back early in my career until I figured out, oh, and it says in the title up there, it says knee anterior view flexed, but a lot of people just gloss over that and don't think about what that means. So you need to flex the knee like this to really see into the interior of the knee to see the cruciate ligaments inside. So we have a medial condyle of the femur, which articulates with the medial condyle of the tibia. Lateral condyle of the femur articulated with the lateral condyle of tibia. The two condyles of the femur actually are united by this continuous sort of horseshoe cartilage. There's a little bit of an indent up here in the cartilage of the femur. That's where the patella would sit, where the kneecap glides back and forth over the surface of the femur. You see that the fibula doesn't really articulate with the knee, although it is connected by a ligament to the femur. So let's talk about some of the other structures here, some of the soft tissue structures. There are two menisci, a medial meniscus and a lateral meniscus. The medial and lateral meniscus are roughly shaped like the letter C. So imagine, I don't know, people at home can see what I'm doing here. So imagine, these two big C-shaped letters facing towards one another. They're made out of fibrocartilage. And a lot of people assume that the meniscus acts as kind of a shock absorber between the femur and the tibia. They think of it as being kind of like an intervertebral disc between the vertebral bodies, absorbing the shock of your knee joint. Turns out that's not true. The meniscus is not a shock absorber. And if you think about the structure of the meniscus, the fact that it's shaped like a big letter C, it's actually empty in the middle. It's hollow in the center. So it's a big C with a big gap in the middle. The femur is resting directly on the surface of the tibia in the center of that big C. And then the C-shaped meniscus just kind of surrounds the area where the femur is resting directly on the tibia. So that meniscus doesn't sit sandwiched in between the femur and the tibia. It just kind of surrounds the area where the femur is in direct contact with the tibia. So if it's not a shock absorber, what actually is it? What is it there for? The meniscus is really there just to provide lateral stability to the knee. It helps prevent the femur from sliding medially or laterally relative to the tibia, or the opposite, to prevent the tibia from sliding medially or laterally relative to the femur. The meniscus acts almost like the labrum in the glenohumeral joint, the glenoid labrum, that surrounds the head of the humerus just a little bit to create a slightly deeper socket. Or same thing in the hip joint. We have the acetabular labrum in the hip joint that creates just a little bit deeper socket to prevent the head of the femur from coming, from being dislocated out of the acetabulum. So it's a kind of a similar thing here. It forms sort of like a labrum surrounding the joint between the femoral condyle and the tibial condyle. There are also some ligaments that help hold the knee together and give the knee a lot of its stability and strength. And the numbers don't mean anything. You don't have to worry about the numbers, but I just numbered them to show that there are 4 of them. Although there's a new one that was discovered recently, or at least named recently. So in the middle of the knee joint are a pair of cruciate ligaments. And cruciate comes from the Latin or Greek root for cross, as in like crucifixion or crucifix. And it refers to the fact that the two ligaments cross one another like an X in the center of the knee joint. The anterior cruciate ligament, or ACL, attaches to the anterior part of that intercondylar ridge, and then attaches to the the lateral condyle of the femur. posterior cruciate ligament attaches posteriorly on the tibia, on that intercondylar ridge of the tibia, and attaches to the inside of the medial condyle of the femur. They both help to stabilize the knee, preventing primarily like sort of anterior posterior dislocation of the knee, preventing the tibia from being pulled too far anteriorly or being pushed too far posteriorly relative to the femur. But they're very commonly injured. So people who are involved in contact sports like hockey, especially American football, to a lesser extent soccer, anything where you are pushing off and making twisting motions, but especially the kind of thing where you're pushing off, making a twisting motion on a 350-pound line that hits you on the side of the leg. That's gonna ruin your day. In addition to the two cruciate ligaments, we also have a pair of collateral ligaments which lie on the outsides of the joint. So we have a medial collateral ligament over here on the medial side, continuing from the medial epicondyle of the femur down here to the tibia. This is the one that's actually a remnant of the adductor magnus tendon. So that's what allows us to describe the adductor magnus as being a hamstring, because it sort of connects to the tibia. And over here we have a lateral collateral ligament running from the lateral epicondyle of the femur down to the head of the fibula. So it's not connecting to the tibia, it's just going to the head of the fibula. I had to add this later because a couple of years ago, I read an article that said that anatomists have now named another ligament in the knee called the anterolateral ligament, which runs from the lateral epicondyle of the femur directly to the tibia, as opposed to the collateral ligament that goes to the tibia. So I put that in there without it. I haven't read any more recent articles about this to see whether there's sort of a general consensus among anatomists if this thing's real or not, or if it's just like a thickened part of the joint capsule, or if people really are recognizing it as a fifth ligament in the knee. These collateral ligaments are especially vulnerable to any kind of lateral impact. So again, you plant your leg and that 300-pound linebacker hits you from the outside. It's going to push your knee inward, pop the medial collateral ligament. The lateral one is harder to injure, but it does happen. You plant your foot like that. Somebody comes in this way, hits you in the medial side of the knee, pushes your knee outward, lateral collateral ligament ruptures. Same structure is just viewed posteriorly. You get a little different view of the cruciate ligaments here. You see in particular how that posterior cruciate ligament is originating way in the back of the tibia and going up to attach to the inner surface of the medial condyle of the femur. And then final picture of the knee with the knee joint completely cut open, the femur removed, looking down on the top surface of the tibia. You get a better view now of the shape of the medial and lateral meniscus. And you can see that each meniscus is a big C shape. So there's a big C-shaped lateral meniscus, big C-shaped medial meniscus. And the femur is in direct contact with the tibia right at the very center of the meniscus, right in the middle of this hole, in the middle of that big C. So the femur is not resting directly on the meniscus. Now, if there's a strong impact to the knee, like if you fall from someplace high and there's a lot of impact on the knee joint, then that thin edge of the meniscus can get crushed between the femur and the tibia. And people do end up with tears to that thin part of the meniscus, right where the femur and tibia are coming in contact. The other thing you can see here is, and once again, you get a good view of the location of the cruciate ligaments and where they're connecting to the tibia. And then you can kind of see the angle of them and get a sense for where they're going to connect to the different parts of the femur. So that's what I have for today. Any questions from here in class or any questions from those of you on Zoom? It's like Will's thumbs up. So. Yeah, all right. So I'm gonna stop sharing if I can get the thing to pop up here. Stop the recording.